Hello friends, this is the last lecture of our endocrine pancreas series. In this lecture we are going to complete our discussion about the diabetes. Right? This is the slide where we left in our previous lecture, how cellular dehydration will occur. Now in our previous lecture we already discussed that due to the hyperglycemia ultimately it leads to glycosuria. Now due to this glycosuria, lots and lots of glucose will enter inside the urine and that glucose will drag water along with it, right? That condition is known as osmotic diuresis of the osmotic diuresis, right? And ultimately lots and lots of water is eventually entered inside the urine. That condition is known as polyuria. Now as we know that there are lots and lots of water is going to get lost in urine, so basically there is increased fluid loss, right? Fluid loss will be increased from the plasma, and the actual plasma, because of the loss of the water, it become hypertonic. So increased fluid loss ultimately leads to hypertonic plasma. So as the plasma become hypertonic, it will leads to increased osmotic pressure of the extracellular fluid. The fluid that surrounds the cell become hypertonic and it increases the osmotic pressure. So ultimately again osmotic diuresis, osmotic drag of the water occurs, osmotic transfer of the water occur from cell to the extracellular fluid. So ultimately the water content of the cell become depleted. That condition is known as cellular dehydration. Now next thing, how the polydipsia will occur. Now more amount of glucose will be present inside the plasma, so ultimately due to the hyperglycemia, more amount of glucose that is already present in the plasma become hyperosmolar, right? And cellular dehydration will occur, that we already discussed in our previous slide. Now due to the cellular dehydration, it will activate the thirst center. Now where this thirst center will be situated? It is situated inside the brain, obviously. Inside the brain it is present over the hypothalamus. Now hypothalamus has a many nuclei, while the nuclei that is related with the thirst, it is known as a lateral hypothalamus or lateral hypothalamic nuclei. So once that lateral hypothalamic nuclei gets stimulated, person will perform excessive drinking, and that excessive drinking of the water is known as polydipsia. Now from this very slide there is one comment asked in July 2013. The comment is like that: polydipsia is common in diabetes mellitus. You have to write it down, all the things that we mentioned in our previous slide, nothing else. Got it? Now how the polyphagia will occur? Next thing of the complication of the hyperglycemia is the polyphagia. Now insulin deficiency leads to decreased glucose uptake, so basically decreased glucose entry inside the cell. So intracellular glucose deficiency will occur. The glucose is not in the sufficient amount inside the cell, so cell is not able to utilize the glucose that is situated outside the cell. So there is a deficiency of the utilization of the glucose. So ultimately satiety center cannot be stimulated, and due to satiety center is not stimulated, there are overaction of the hunger center, and ultimately it will lead to excessive eating. Now you might be thinking where the satiety center will be there. Where is the satiety center? Inside our brain, right? Again it is situated inside the hypothalamus. See, thirst center is present over the lateral hypothalamus. The satiety center on the opposite hand, it is situated inside the medial aspect of the hypothalamus. The name of the nuclei is ventromedial nuclei, and due to unstimulated satiety center, see, most of the time when the satiety center get activated, it inhibit the hunger center. Now in our cases, due to glucose do not enter inside the satiety center nuclei, it will leads to ultimately overactivity of the hunger center, and ultimately that condition is known as polyphagia. Now again from this very slide there is one comment asked. The name of the comment is like this: polyphagia occur in hyperglycemia of diabetes mellitus. Again you need to write it down, all the things that we mentioned in our previous slide. Alright. Now the next thing is that if the hyperglycemia in the diabetes mellitus will be present for more period of the time, it will leads to glycosylation of the protein. They are simply adding the glucose over the protein. See, like this, there is a coating of sugar over this pancake. Same fashion, coating of the glucose will be take place over the protein. And the most important protein that we are interested right now is the hemoglobin. So glycosylation of the hemoglobin will occur. That glycosylated hemoglobin is known as HbA1c. Now what happened in glycosylation of the hemoglobin or HbA1c? Same thing that I mentioned, condensation of the glucose will take place. Now where this condensation of the glucose will take place? So you know already the hemoglobin has a two compound, heme and globin. Now inside the globin is a protein, right? So basically glycosylation of the protein will take place. So somewhere inside the globin this glycosylation should occur, right? So in glycosylation of the hemoglobin, that glycosylation of the adding of the glucose will be occur in beta chain, where inside the beta chain basically the valine of each beta chain. Now normally the glycosylation is also present. That normal amount of the glycosylation is about 3 to 5% of the total hemoglobin. So yes, the person do not have diabetes also have a glycosylated hemoglobin, but the person who suffer from diabetes mellitus have a more amount of that glycosylated hemoglobin, and the actual amount is 10 to 20% of the total hemoglobin. So you see, if the person suffer from diabetes mellitus and his glucose concentration is well maintained, the person is taking the medication regularly, then the blood sugar do not rise up to certain limit, so there are less chances of the glycosylation of the protein. And if that glycosylated hemoglobin is more, it will leads to more it causes the more amount of glycosylation of the hemoglobin. So that glycosylated hemoglobin HbA1c is very important tool in monitoring the diabetes control. If the person says that he is taking regular drugs and treatment or regular injection of the insulin, and if once you measure the actual amount of the HbA1c, and if it is more than this 10 to 20%, then you can easily diagnose that person is not taking the medication regularly. Now the next thing is the microangiopathy. Same thing will occur with the blood vessel as the glycosylation of the protein. There is a glycosylation of the capillary basement membrane, that known as a microangiopathy. The capillary basement membrane become thicker due to structural changes caused by glycosylation. So in the other word, it is nothing but the glycosylation of the capillary basement membrane. What? Three type of microangiopathy that you need to keep in mind. One is the diabetic nephropathy, that is related with the kidney. Next one is the diabetic retinopathy, that is related with the eye. And last one is the diabetic neuropathy, related with the neuron. Now this is all about the hyperglycemia and its complication. Now let's discuss about the hyperlipidemia and its complication. Now that hyperlipidemia and its consequences we already discussed in our action of the insulin and what happened when the insulin is absent, right? So let's summarize that discussion. Now whenever there is an insulin deficiency, what it will lead to decrease utilization of the glucose, and it use more fat for the energy, right? So whenever we use more fat for the energy, there are chances that there are more amount of fat will be released from the adipose tissue, right? That condition is known as lipolysis, because of the higher amount of stimulation of hormone sensitive lipase and less amount of the stimulation of lipoprotein lipase. You know, there are two type of the hormone. One is lipoprotein lipase, another one is hormone sensitive lipase. Now once the insulin is present in a proper amount, that lipoprotein lipase enzyme will be stimulated, and it will facilitate the transfer of the fatty acid inside the adipose tissue. And that insulin also inhibit the hormone sensitive lipase, so there are less chances of lipolysis. Now in the diabetes mellitus, due to insulin deficiency, ultimately there are inhibition or less stimulation of the lipoprotein lipase, so no more fatty acid will be entered inside the fat cell. On the other hand, hormone sensitive lipase are free from the inhibition, and it will leads to breakdown of the triglyceride inside the fat cell and will release free fatty acid. So ultimately more amount of free fatty acid will enter inside the circulation. That condition is known as hyperlipidemia. And this hyperlipidemia, more amount of free fatty acid will enter inside the liver, and inside the liver there are more amount of formation of the cholesterol and phospholipid, and ultimately person will suffer from atherosclerosis, right? Now here's the thing, if this free fatty acid level is more, then there are transfer of the free fatty acid inside the mitochondria by a carnitine pathway. Ultimately it will leads to increased formation of the ketone bodies. Now you know there are three type of the ketone bodies. One is acetoacetate, another one is the beta hydroxybutyric acid, and last one is the acetone. Now once these ketone bodies will enter inside the circulation and the number of the ketone bodies is increased, that condition is known as ketosis. Now these ketone bodies are actually acidic, so basically they are going to decrease the pH of the blood, and that acidosis that is done by ketosis, that acidosis is known as ketoacidosis. And in the severe form of the ketoacidosis in the diabetic mellitus patient, it is known as diabetic ketoacidosis. In short form it is known as DKA. DKA is the emergency situation. Now out of these three ketone bodies, this acetone will be used for the diagnosis purpose. It is diagnosed by acetone breath of a person or patient. Now what is this acetone breath? Acetone breath is a rapid and deep respiration is present inside the diabetes patient, and ultimately person have a dyspnea, difficulty in breathing. That type of the breathing, it is known as Kussmaul's breathing. Got it? That condition will be present in the severe diabetes, and person will go into the decay. When the person go into the decay, there are more amount of acid inside the person's blood because of the ketosis. This less pH or acidosis will ultimately stimulate the respiratory center, and it will lead to deep and rapid respiration. It is known as air hunger, and there is a difficulty in breathing. So both this rapid and deep respiration with dyspnea in diabetic ketoacidosis patient is known as Kussmaul's breathing. Now once there are more amount of fatty acid inside the circulation, that fatty acid, as I told you, is converted into acetic acid, and if there are more amount of acetic acid, it will lead to increased formation of the acetoacetic acid. If there are greatly increase in acetoacetic acid in the severe diabetes, it ultimately converted into the acetone. Now there is one good thing about acetone, that acetone, once it forms, acetone is actually volatile. It is easily vaporized and it is expired in air, right? Now that acetone will be expired in air will be known as acetone breath, and you can easily identify by smelling the acetone of a patient suffer from the diabetes mellitus, because it smells same as a nail polish remover. You guys are familiar with this smell, nail polish remover. So doctor can frequently make a diagnosis of a type 1 diabetes by simply smelling the acetone on the breath of the patient when the pH of the blood falls less than 7. So basically when person suffer from acidosis. An acidotic coma and death might occur within the hours if we do not treat the patient. So diagnosis of type 1 diabetes will be made simply by smelling of the breath of the patient. Now how can we diagnose the diabetes? So there are two urinary tests, urinary glucose, and another one is urinary ketone bodies. Now urinary glucose is very simple and very easy. We are going to use this strip that is shown over here. It has a different color coding over here, and there are appropriate changes will take place once you dip this strip in the patient's urine, right? But here's the thing, the amount of glucose that is filtered in urine of that particular patient depend on the renal threshold, and different person has a different type of the renal threshold, so this test is not actually accurate, right? And the next one is the urinary ketone body. The same type of strip will be available. You have to just take a patient's urine and put it over this, and you have to dip this strip, and along according to the color coding you can easily identify the presence of the ketone bodies inside patient's urine, right? Now the actual diagnosis of the diabetes will be done by the blood sample, right? First one is the fasting blood glucose. You have to measure the blood glucose while the person is in fasting. Let me show you an actual figure. See, normal subject has a less than 100 milligram per deciliter of the normal blood sugar, right? And person suffer from diabetes has a more than 125 milligram per deciliter. So normal subject has a less than 100 milligram per deciliter of the glucose, and diabetes patient has more than 125 milligram per deciliter of the glucose. Now here's the thing, the glucose level that fall under these two, normal and diabetes, that is 100 to 125, that is known as pre-diabetes. In mostly it will be use the different terminology, that is impaired glucose tolerance. Now what is glucose tolerance, that we discuss in our next slide. Now fasting blood sugar, the normal, it is about less than 100 milligram per deciliter and 100 ml. Now see the glucose, next one is the glucose tolerance test. Now how this glucose tolerance test will be done? Now by simply the meaning of glucose tolerance, that we have to just load the glucose inside a patient or a subject and see how well the person's endocrine pancreas will tolerate that load of the glucose. So normally what would happen, once you load the patient with the glucose, that glucose ultimately leads to increased release of the insulin, and that insulin will ultimately leads to decrease glucose level by increasing the uptake of the glucose. So we have to just check how much amount of the insulin will be secreted by patient. In other words, how good the patient to tolerate the glucose load. Now how can we perform this glucose tolerance test? So first thing first, if you are going to perform the test tomorrow, no food or drink would be taken 8 p.m. prior to the test. If you are going to test the subject in the next morning, the tomorrow morning, then the patient should not drink or eat anything after 8 p.m. today, except water obviously, because water do not have any kind of glucose. Now on the test day, first when the person appear in the clinic, you have to take a blood sample. That blood sample is the fasting blood sample or fasting blood glucose. After taking that sample, just give 75 gram of the glucose in 1 glass of the water, that is 250 ml on the test day. So first take a blood sample fasting, then after taking that blood sample, just give a glass of water filled with 75 gram of the glucose in 250 ml of the water on the test day. Now how GTT is done? Now after giving the glucose, there are two type of GTT. One is the conventional method, another one is the mini GTT, that is given by WHO. Now what we have to perform in conventional GTT? In conventional glucose tolerance test, we have to take a total 6 sample for every 30 minutes. So ultimately in conventional GTT, you have to prick for 7 times. It is painful, right? You have to take a blood sample 7 times and total 6 times and every 30 minutes. And this 7th one, the next one is the fasting blood glucose. Now what we have to perform in mini GTT? In mini GTT only two blood sample will be collected. One is the fasting blood sample, fasting blood glucose sugar, and the second one is 2 hours after loading the glucose. It is known as PP2BS. Now the full form of PP2BS is postprandial blood sugar after 2 hours. Alright, so the mini GTT is more convenient as compared to the conventional one. Now how you have to show the result of the GTT? Now as far as this conventional GTT is concerned, this is the diagram or the graph showing the conventional GTT result. See, in y-axis it's shown the blood glucose level, in x-axis it's shown the time. So this red color margin or red color graph that is present over here, it's shown the normal glucose tolerance. What it person's blood glucose level do not raise more than the renal threshold. See, the renal threshold, the dotted line will be shown at 180 mg per deciliter level. So in normally, once you load the patient, subject blood glucose level will initially rise and then fall. Now what will happen in the impaired glucose tolerance? This is about the normal glucose tolerance, red curve, and the blue curve is the impaired glucose tolerance. See, in impaired glucose tolerance, person is not fit for the diagnosis or not complete the criteria of diagnosis of the diabetes, but yet its glucose level is more than normal. See, this blue curve will be cross the renal threshold and then again it will reach to the normal level, but more slowly than normally. So person does have small amount of insulin, the person can tolerate the glucose, but that tolerance is impaired, that is known as impaired glucose tolerance. And the last one is the gray bar, this one is the diabetes. The person's blood glucose level reach more than 250. You can see in this diagram, after 1 hour person's peak glucose concentration reach more than 250 milligram per deciliter. So this graph is actually the showing the GTT of the conventional method. Now how will you interpret the mini GTT? Let's show that thing, the interpretation of the mini GTT. In mini GTT, the normal person having a fasting blood sugar is less than 100 milligram per deciliter, and PP2BS after 2 hours of the loading the glucose, the level will be less than 140 milligram per deciliter. In impaired glucose tolerance, person having fasting blood glucose level fall under the 100 to 125 milligram per deciliter, and PP2BS will be 140 to 199 milligram per deciliter. Now the person that suffer from diabetes mellitus having the fasting blood glucose level more than 126 milligram per deciliter, and PP2BS is more than 200 milligram per deciliter. So this is how you should interpret the GTT, mini GTT. Now according to the WHO, what are the criteria of diagnosis of the diabetes mellitus? That criteria that I am taken from the Harrison, the book of the medicine. So remember the criteria for diagnosis of the diabetes mellitus. So in exam, if in Viva, if any examiner asks you the criteria for diagnosis of the diabetes mellitus, it is not simply the symptoms of the diabetes mellitus, yet you need to give a proper figures. First figure is the fasting blood sample, fasting blood sugar, it is more than 126 milligram per deciliter. PP2BS, it is more than 200 milligram per deciliter. Right, this is two from the GTT, the mini GTT. And the last criteria is about the glycosylation of the hemoglobin HB1C, it is more than 6.5 percentage. So these are the three criteria of the diabetes mellitus. Now along with this figure, symptoms of the diabetes mellitus should also be present for the diagnosis of the diabetes mellitus. What are the symptoms? Polyuria, polyphagia, polydipsia and weight loss. These are the symptoms of the diabetes mellitus. So along with the criteria, along with the FBS, PP2BS and HB1AC, symptoms should also be present. Now this is all about the criteria of diagnosis of the diabetes mellitus. Now let's take a small portion of the treatment part. Treatment of the type 1 diabetes mellitus. Now you know that in type 1 diabetes mellitus, the problem is with the release of the insulin, the synthesis and release of the insulin. The person who suffers from type 1 diabetes due to the viral infection or autoimmunity, the beta cell of the pancreas is destroyed. So person cannot able to form a insulin in normal range. So the ultimate treatment of the type 1 diabetes is we have to give the insulin, exogenous insulin from the outside, the injection of the insulin. So in past, insulin was derived from the animal. See, the pork insulin and the human insulin has only one amino acid differ, right? But nowadays we do not use pork insulin, rather we use recombinant DNA technique and produce the new human insulin, right? Now insulin is also available in several forms, but the most commonly used one, the form is known as a regular insulin. That regular insulin has a half-life about 3 to 8 hours. And the other form of the insulin that we mentioned in our, that we written down in our this one, the several in the other form other than the regular insulin, they are absorbed more slowly from the injection site, so they can have a more amount of longer half-life, see, from 10 to 48 hours, right? Now what about treatment of the type 2 diabetes mellitus? See, the main cause of the type 2 diabetes mellitus is that person have a normal amount of the insulin, the beta cell of the person has a normal functioning, but the problem lies on the action of the insulin. There is an insulin resistance, so insulin is present but not able to act via receptor. So how will you cope up with the insulin resistance? The first modalities that doctor use are the dieting and exercise. You have to ask the subject to diet and do perform exercise. So basically weight loss, we have to just make sure the person weight will be decreased, because in fatty person, because of the higher amount of the fat tissue, it will, the fat will, that will causes the insulin resistance. The cause of the insulin resistance is mostly the fat. So once the weight loss will be occur, less amount of fat inside the person's body, it will lead to reverse the insulin resistance. Now if this dieting and exercising strategy fail, then we have to give a drug. Now what kind of drug that we have to give to the subject? That kind of drug, that drug will be increase insulin sensitivity and also stimulate the more amount of insulin by pancreas, right? So in type 2 diabetes, we have to give a drug that increase insulin sensitivity and stimulate the more amount of insulin release. Now let's enumerate certain drug used from the type 2 diabetes. So we are not going into the detail of the drugs that we use in type 2 diabetes, it will actually like 2 to 3 hour lecture. So just we are just summarize, or we are just mentioning the drugs that increase the insulin sensitivity. That drugs that insulin increase the insulin sensitivity, that group of drug is known as thiazolidinediones. Remember the name, thiazolidinediones. You should remember in pharmacology. You must remember in the pharmacology. So if you can able to understand, remember in physiology, it will good for you. Next one is the drug that suppress the liver glucose production. So drug that decrease the gluconeogenesis, that set of the drug is known as metformin. Next one is drugs that causes additional release of the insulin by pancreas. Now that particular drug we already discussed the mechanism of the action is the sulfonylurease. In the mechanism of action of the how glucose leads to insulin secretion, right? We already discussed how sulfonylurease will work. Sulfonylurease will work via blocking the ATP sensitive potassium channel that is situated over the beta cell. So ultimately sulfonylurease will leads to accumulation of the potassium inside the beta cell. Once the potassium will accumulate it will leads to depolarization of the cell. That depolarization of the cell will ultimately leads to opening of the voltage gated calcium channel. That voltage gated calcium channel will leads to increased calcium influx, and that increased calcium influx ultimately leads to the exocytosis of the secretory vesicle of the beta cell that contain insulin. Right, this is how the sulfonylureas will work. Now there are set of the drug that mimic the action of the incretins GLP-1 and GIP. Right, that set of the drug will enhance the secretion of the insulin. Now the last one is the newer drug, that is the enzyme dipeptidyl peptidase 4 inhibitor or DPP4 inhibitor. What DPP4 is that drug? DPP4 inhibitor is known as DPP4 blocker. Now what DPP enzyme do? That DPP enzyme will inactivate the GLP-1 and GIP. Now you know already that GLP-1 and GIP are incretins. If they are inactivate fast, then the secretory action over the insulin will be less. So what this DPP4 blocker do? It will block the enzyme DPP4 and it will make sure that availability of GLP-1 and GIP is more. So incretins of GLP-1 and GIP can be present for prolonged period of the time and it will lead to increased insulin secretion. Now this is all about our endocrine pancreas. Now next time in next lecture we are going to discuss about the adrenal medulla. Thank you.